Aloha and welcome to our series, Nursing and the Human Body. We are going to talk about the heart today, and we're going to start out by discussing coronary artery disease. Here we can see the heart, and we can see all of the coronary arteries identified. And these are the arteries that supply the heart with oxygen-rich blood. These coronary arteries can become narrowed over time. The narrowed arteries limit the amount of blood supplied to the myocardium, especially during strenuous activity. So let's talk a little bit about some of the risk factors for the development of coronary artery disease. There are non-modifiable risk factors like age. Age plays a vital role in the deterioration of cardiovascular functionality. Older adults, they're at an increased risk for cardiovascular disease. Gender is also non-modifiable. Heart disease is the leading cause of death in the United States for both men and women. Although we know that coronary artery disease kills more men than women, it's actually a statistic that more women die of heart disease than breast cancer. So heart disease is a big problem for both men and women. Ethnicity is another non-modifiable risk factor. African Americans have the highest risk of death from heart disease. Genetics is another risk factor that we can't really do much about. If we're born with a predisposition to having heart disease because we've got it running in our family, then we're going to have a higher risk for developing it in our lifetime. There's also something that's significant in coronary artery disease risk, which is familial. It's familial hypercholesterolemia. Now, if we break that word down, it means hyper, as in a large quantity, too much, cholesterol, which really just refers to the fat, and emia in our blood. So hypercholesterolemia is too much fat circulating in our blood. Some of the modifiable risk factors are elevated serum lipids or fats, hypertension, smoking, sedentary lifestyle, obesity, and diabetes mellitus. So we said before that sometimes having these elevated lipids in our blood is genetic. There isn't anything we can do about it. On the other hand, this can be modifiable as well. For example, if you cut down on the amount of fats and cholesterol in your diet, in some cases, we can decrease the amount of fats in our bloodstream. So let's talk a little bit about these triglycerides or lipids. These are fats that circulate in the blood. And so the risk of coronary artery disease is increased when these fasting triglyceride levels of greater than 150 milligrams per deciliter. Fasting triglyceride means that you haven't had anything to eat or drink for about 8 to 12 hours before the lab is drawn. The risk of coronary artery disease is increased with a serum cholesterol level of greater than 200. Foods that are higher in cholesterol include egg yolks, red meat, cheese, and pork. And so we're not saying that these foods need to be avoided completely. What we're talking about in an individual with high cholesterol is that we want to modify the diet and so that we're not taking in a lot of these types of food. We want to take these foods in moderation. We want to balance this out with other foods like vegetables and fruits, and especially green leafy vegetables. So low-density lipoproteins, these are the LDLs, and these are kind of referred to as the bad cholesterol. These have an affinity for arterial walls. An elevated LDL is associated with increased risk of atherosclerosis. We're going to talk a little bit more about that here in a bit. So the risk of coronary artery disease increases when our LDL is greater than 130. High-density lipoproteins are what we refer to as kind of like our good cholesterol. These carry lipids away from the arteries to the liver for metabolism. So these prevent lipid accumulation within our arterial walls, and the desirable levels are 37 to 70 for men and 40 to 88 for women. So this is one lab where we actually like to see the higher number, the better. So we said before that these coronary arteries that supply the heart with oxygen and blood can become narrowed over time. And these narrowed arteries limit the amount of blood supplied to the myocardium, especially during strenuous activity. So here we can kind of see one of the coronary arteries blown up a little bit for us. And now in this image, we're looking down the lumen of a normal artery, and we're looking down the lumen of an artery that is diseased with atherosclerosis. So let's watch a video that's going to kind of show us what atherosclerosis looks like as these lipids are accumulating, this fatty streak. It kind of embeds itself into the endothelial tissue in the wall, and then eventually platelets will start sticking and a blood clot will form. So here we can see some damage to the endothelial wall. And these streaks, we see some lipid accumulation. Now you can start to see where some blood platelets will come in and start sticking until you have a complete blockage. So let's kind of break that down and take a look at that more carefully. So the progression of atherosclerosis is kind of all here in this pictorial, and what we're going to do is we're going to go through each one of these in a little bit more detail. So first what we have is a damaged endothelium, all right? And the things that can damage the endothelium include hypertension, tobacco use, hyperlipidemia, or too much fat in the blood, and hemodynamic factors, diabetes, infections, and even immune reactions. So anything that causes injury to the lining of the artery. And then what happens is after this damage takes place, there's an immune response. Monocytes, which are white blood cells, and platelets and macrophages are sequestered to ingest the dead cells and fat accumulation that's present in the intima. So here's the endothelium, the inner layer of the arterial wall, becoming damaged, and we can see these platelets coming in, the macrophages, the lipid accumulation. And then what happens is it can't repair itself. The endothelium cannot repair itself, and these little fissures or tears are left, and a hard collagen cap ends up forming. So here we can see the collagen cap. We can see where there's these fissures in the plaque, and then we can see this little pool of lipids behind that. The lesion becomes more complicated when the platelets come in and stimulate protein receptors that attract fibrinogen, and a clot is actually formed, all right? So now we have an actual thrombus formation, and that is going to contribute to the narrowing of the artery until the blockage could either be complete or partial. And so in the complicated lesion, these platelets begin sticking to the wall, and they stimulate a receptor that binds fibrinogen, and a thrombus forms. And what happens then is blood can be cut off. The blood supply to the myocardium, to the muscle, can then be cut off because this clot is in the way. So here what we see is an example of something called collateral circulation. It's pretty amazing that our body can actually grow new circulation. We can see in the picture on the right where the clot is there, and we see this new collateral circulation forming to restore perfusion to the myocardium. We can see on the left we've got normal circulation, and once that blockage occurs in the image on the right, we can see how the heart will actually start growing new vasculature to make sure that the myocardium gets the supply that it needs. Here's another example of collateral circulation where you see a blockage in the heart, and you see these small little blood vessels all growing out around the area of blockage in an attempt to perfuse the myocardium. So prevention is the key, right? We want to try to teach our patients what they need to do in order to prevent this from happening, to prevent getting coronary artery disease and prevent blockage. However, it's never ever too late to start. So even once we know somebody's developing hypertension, maybe they're developing coronary artery disease because we know they have high cholesterol, we want to first teach them how to achieve and maintain a healthy weight. We want to reduce their salt or their sodium intake by decreasing the amount of salty foods that they eat. We want to increase their level of physical activity. We want to have them avoid tobacco products or to quit smoking and limit their alcohol intake. And we also want to help them choose a heart-healthy diet. So our goals are to reduce triglycerides, reduce the LDLs, the low-density lipoproteins, raise the HDLs, the high-density lipoproteins, and keep that blood pressure under control. So let's talk a little bit about myocardial ischemia. If the demand for myocardial oxygen exceeds the ability of the coronary arteries to supply the heart with oxygen, we have a situation that we call myocardial ischemia. And this results in angina. So all the physiology that we just looked at, the blockage that will occur in the coronary artery can cause chest pain. And we call this chest pain angina. Stable angina is predictable chest pain. So this is directly related to the amount of exertion, and it does not occur at rest. So an example of this would be that the patient says that they know that they get chest pain, let's say, when they go out and rake the leaves in the fall. They can predict that when they go out and do some raking of leaves and bagging up, that it's a little bit more exertion than it is when they're just sitting at rest, and they tend to get chest pain. So again, remember that stable angina does not happen when a patient is just sitting and resting. Unstable angina is unpredictable chest pain, which can occur at rest. And so if we have angina pectoris, when a patient is just sitting down resting or doing something that they normally do that doesn't cause chest pain, then we refer to this as unstable angina. There's also a different type of angina that is called a vasospastic. This is a condition where there's a spasm of the coronary arteries that does cause chest pain, but it's not actually associated with atherosclerosis. It's not associated with blockage in the coronary arteries. So let's talk about some of the clinical manifestations of acute coronary syndrome. So this is when the blockage has gotten severe enough, the patient is experiencing unstable angina, and they say, I'm having chest pain. I feel like an elephant is standing on my chest. I can't catch my breath. The individual may actually clutch their chest. They may be observed to look like the gentleman that you see here. And this can be very scary. And so you're wondering, is this an episode of angina, or is this a myocardial infarction? And how do we know? Well, we need information. We need to know what the precipitating events are, what caused it, what brought it on, what is the quality of the pain. Is the pain radiating to anywhere else in their body, like maybe down their left arm, up into their shoulder? What is the severity of the pain on a 0 to 10 scale? The timing of the pain, is it constant or does it come and go? We want to know if the patient is experiencing short of breath. We want to look at their skin color. Are they cyanotic? Do they appear like they are blue? Remember, pink is good, blue is bad. Oftentimes, the patient will say they have this feeling of apprehension or impending doom, and this pain which is crushing that may or may not radiate. So diaphoresis or sweating, nausea, feeling sick to their stomach, they may even start to vomit, and they may be having arrhythmias as well. So how do we know, right? Well, anyone who's having chest pain that's not relieved by the nitroglycerin pills that usually they will have for angina that they take sublingually will require us to probably call 911 and have them evaluated in the emergency department. And some of the things we'll do is that we'll draw some labs, and we'll be looking for cardiac markers. These are biochemical markers that will be in the bloodstream when there's been damage to the heart muscle. So these enzymes and proteins will be released if there's damage to heart muscle. So one example of this is CKMB, or creatine kinase. This is an enzyme. It's specific for myocardial injury. It rises about 4 to 6 hours after the injury to the tissue, and it peaks at about 18 to 24 hours. Now, troponin is actually a better cardiac marker because, again, it's also released into circulation after myocardial injury. And there's usually none circulating. So the presence of this one is significant, but it's detectable 1 hour following injury. So this one tells us that there's been injury to the cardiac tissue really soon after the injury has taken place. There's another lab that's a cardiac marker, and this one is a little bit more specific for congestive heart failure. And this is brain natriuretic peptide, or B-type natriuretic peptide. This is a protein that's produced by the heart and blood vessels. It can rise following damage to the heart, and its action actually eases the strain on the heart. And this is because it helps the body eliminate fluids, this natriuretic peptide. It relaxes the blood vessels, and it actually funnels sodium into the urine to help the patient get excess fluid off. And normally the BNP of greater than 100 might be an indication that the patient is suffering from some heart failure. The other thing that we might look at is EKG. And here we can see an ST segment that is elevated. We see on the top a normal EKG, and on the bottom we see STEMI, or ST elevation. So let's take a look at what that means. ST elevation in a myocardial infarction means that there's an elevation in the ST segment that's telling us that there's a blockage of one of the heart's main coronary arteries. So we talked about this blood clot forming, and when we see this on EKG, it's telling us that our patient has a larger main artery blocked. And that's to be contrasted with non-ST elevation. Non-STEMI is when there is an occlusion, and it could be a complete occlusion, but it's of a minor coronary artery, or partial occlusion of a major coronary artery. And this does cause damage to our heart muscle. In the case of non-STEMI, we are having damage to the heart muscle, and of course in the case of STEMI, we're having damage to the heart muscle, okay? The standard practice in treating a patient that comes in complaining of chest pain that has the labs and the EKG that might be indication that they're having acute coronary syndrome or myocardial infarction has always been MONA. That's how we remember it, MONA. Morphine, oxygen, nitroglycerin, and aspirin. However, it's important to note that the standard of practice is changing, and this is due to new evidence that's recently come out. We have found that morphine may be associated with decreased absorption of the antiplatelets, a larger infarct size, and increased mortality or death in cardiac patients. And so we're rethinking whether or not we should be giving morphine. We're also looking at oxygen and saying that studies have shown that oxygen might increase the size of the infarct and may not actually help reduce the pain, okay? And so now we have kind of a newer MONA that we want to consider. And so we said before that MONA is the acronym traditionally taught to overview the treatment for acute chest pain due to suspected myocardial ischemia or infarction. However, morphine and oxygen should actually be avoided in some patients. All right, so we're rethinking this now, and what they're finding is that we should be checking the patient's oxygen saturation, and if their oxygen saturation is greater than 94 or 95%, that we probably should not put them on oxygen. All right, so let's talk a little bit about cardiac muscle cells. So each separate cardiac muscle cell can repeatedly contract or beat by itself at its own pace. But that is not what we're aiming for. It's important that all the cardiac cells work together in synchrony. We have certain specialized heart muscles. These help us conduct the signal and maintain the synchrony of our heartbeat, all right? And so this conduction pathway is very important. There's going to be a handout available for you to read about this in a little bit more detail, but right now we're just going to kind of go through the steps. The very first thing that happens is our sinoatrial node of our right atrium sends an electrical signal. It sends a signal, atrioventricular node, down from the right atrium into the right ventricle. And so what happens is the sympathetic neuron It's norepinephrine is the hormone, increases our heart rate, okay? So here we can see a sympathetic neuron kind of stimulating the SA node, right? So let's kind of go back here and take a look. So we've got stimulation of the SA node, then we have stimulation of the AV node, and then we can see here the whole process taking place all at once. On the opposite side of the spectrum, we have the parasympathetic neuron, and it's acetylcholine that's the hormone involved here. This decreases our heart rate, and so here we can see this type of stimulation causing less stimulation and a lessening or decreasing of the heart rate. So let's take a look at kind of what we looked at a little bit before. We talked about this ST elevation. Let's take a look at a wave. We're gonna look at the P wave, the Q wave, the R wave, S wave, T wave, and what these mean. So the P wave is really like the atrium getting excited. All right, and that's the tracing on our EKG that shows us the P wave. It's atrial excitation. Next thing that happens is the QRS ventricular interval, okay? So the QRS interval is the ventricular excitation, all right? So it's kind of like the bang, all right? The heart beating. And then we get repolarization, which is the T wave. We can think of the T wave as the reset button. So the P wave we can think of as lighting the fuse. The atria get excited. The QRS interval as the ventricles getting excited. And the T wave as repolarization or the reset button. So if we take a look here, we can see a sinus rhythm. Okay? So if you watch this, you can see the P wave, you can see the QRS interval, and you can see the T wave. So remember, we said we want to see a perfusing rhythm, which is when all the cardiac cells are working together in synchrony. If each separate cardiac muscle cell repeatedly can contract or beat by itself at its own pace, we end up with something called fibrillation, okay? And this is not good. This is not what we want. When the ventricles, which are the main pumps, are fibrillating, there can be no heartbeat. Ventricular fibrillation, or V-Fib, looks like this on the telemetry tracing. Do you see a P wave? Do you see a QRS interval? Do you see a nice T wave? No. We do not see a nice organized heart rhythm. Ventricular fibrillation is bad. No pulse. We have to do chest compressions. The patient needs oxygen. We call for help. We need the crash cart. The patient is going into shock and requires advanced cardiac life support, or ACLS. But don't confuse ventricular fibrillation with atrial fibrillation. This is what's happening in atrial fibrillation, okay? So we see this tracing and we're like, well, we do see a QRS. We kind of see some P waves. We kind of see some T waves, but little disorganized as well, okay? And so what's happening here is we've got the atria kind of sitting there and kind of quivering, right? The atria, this is atrial fibrillation. This is a major cause of strokes in our patient. It's one of the main reasons that we give a drug called Coumadin. And we don't want to convert A-Fib to a sinus rhythm until we know there is no thrombus. So we can have A-Fib that might be stable or unstable. And how are we going to know that? We're going to know that by monitoring our patient. We want to look at their color. We want to monitor their telemetry. We want to know their heart rate. We want to know how well they're breathing, if they're feeling short of breath. So in atrial fibrillation, we want to shock this if it is unstable, okay? If it's stable, we probably want to obtain an echocardiogram to rule out atrial thrombosis first. And we're going to talk about what transesophageal echocardiogram is in a little bit. So here we can see what happens in A-Fib is that part of a thrombus may break off and become an embolus. So remember, if the atria are just kind of sitting there quivering, what happens when blood kind of sits still? It tends to clot, right? When blood is pooling, it clots. And so what could happen is an embolus could form, and it could travel through the bloodstream and reach a blood vessel too small for it to pass through and block that vessel. And so an emboli commonly can come from the heart, where different diseases can cause thrombus formation, and atrial fibrillation is one of those conditions. So let's talk a little bit about some of the diagnostic testing that we can do to find out about different heart problems that our patient can be having. And first we're going to take a look at chest x-ray. We can use a chest x-ray to view the heart, and we can look at the size of the heart. We can look and see whether or not there's fluid in the lungs, and we look for widening of the mediastinum. So in the x-ray here, you can see a heart that is quite enlarged. And over on the right in the picture, it says heart hypertrophy due to congestive heart failure. So the picture on the right kind of shows what the heart would look like in the patient's chest cavity, but on the left we can see what this would look like on x-ray. We can also do an EKG, and we've talked about this in this lecture. We can do an EKG so we can record the heart's electrical activity. And so the EKG shows a recording of the electrical signal and how well that is repolarizing the heart. So if we kind of read through our sequence of events here during an ECG tracing, we're looking at each heartbeat at the first perceptible event on it, and the combined electrical excitation of the atrial tissue that corresponds to the P wave in the EKG, and then the period that follows during which the atrial contraction occurs and excitation travels through the AV node, followed by excitation of the ventricles, which then we end up with our QRS complex of the EKG, and then our ventricular tissue remains uniformly excited and then recovers during the T wave. In a transesophageal echocardiogram, what we're doing is we're getting a direct view of the atrium, and we may be able to locate clots in the atrium. And so what would happen in this case is that we could treat the patient with Coumadin, and we could also make a decision for whether or not to shock A-Fib. Okay? So again, here's another image of our A-Fib where we have an embolus. An echocardiogram is a way that we use sound waves to produce the image of the heart. Okay, so this is actually looking at pictures. The image from the echocardiogram can identify various abnormalities in the heart muscle and valves. indicates how well the heart is beating and pumping blood. So we can do a standard non-invasive echocardiogram where we would put gel on the chest wall and a transducer is pressed against the skin aiming at the heart. And it records sound waves that converts, the computer converts these into moving images. So let's take a look here. Here we can see the technicians. We see the transducer, and we can see that it's creating images then of the heart as it's beating. And then the physician, the cardiologist, can read the results and identify different problems that are happening in the patient's heart. Okay. Next, we're going to talk about a stress test. So a stress test is when we actually have our patient stand up on a treadmill and exercise while we monitor for changes in the EKG that are produced by exercise. And so we will have a blood pressure cuff on our patient. There will be electrodes attached to the chest. These electrodes are connected to a machine. The patient walks on the treadmill. The nurse will be monitoring the blood pressure, and the electrocardiogram will be recorded. And this is kind of what this would look like. Here you see the patient walking on the treadmill. You see the physician there. There's usually a technician. There could be a nurse there helping to monitor the patient. We can see the electrodes. And then later on, we can take images. Sometimes we use isotopes called cardiolite. We put this into the IV, and when this moves through the bloodstream into the heart, it helps us take some pictures to see how quickly the heart will draw up the isotope. Okay, so cardiolite is another part of the stress test when we have the patient exercise on the treadmill. The thallium moves through the blood and goes into the heart, and we see if the heart muscle does not have enough blood supply, it could take up the isotope slowly or not at all. Okay, so 1 hour after the exercising, we take some nuclear imaging of scans of the heart, and it can show areas of narrow or blocked vessels or areas of damaged heart muscle. You'll also hear people talk about getting a cardiac catheterization. And this is when a guide wire is inserted into the femoral artery of the leg and threaded up into the aorta. A catheter is then inserted along that guide wire. So here we can see an image of the catheter coming up through the groin up into the aorta, either through the femoral artery in the groin, or we can also use the brachial artery in the arm. That's an alternative site. Once it's in place, we inject a dye that can be seen on X-ray. This contrast dye is injected into the bloodstream, and then what happens is areas of narrowing can be seen on a video screen and recorded. So angiography, all right, coronary angiography and coronary arteriography are the same thing, all right? So coronary means heart, angio means blood vessels, and graphy means pictures or images. And so what we're looking at here in a coronary angiogram, it's part of the cardiac catheterization procedure. In which we get a visual X-ray image that identifies narrowed or blocked coronary arteries. And this is kind of what it looks like. Here we can see those coronary arteries supplying the heart. And we have a little video here. If you watch it carefully, you can see the vessels fill up. So you can see the heart pumping there, and you can see where the heart arteries are filling up. One more time. There you go. That's a really good one. So remember, angiography is to take a picture, be able to see it. All right, so angioplasty is something that we can also do during cardiac catheterization. So angio is blood vessel, artery. Plasty means to mold or form through surgical intervention. So let's take a look here. Here we see the balloon going up into the artery. We see the balloon opening up the artery and then being removed. So this is called balloon angioplasty, where we're temporarily inserting and blowing up a tiny balloon where the artery is blocked to widen the artery. It's often combined with the placement of a small metal coil called a stent in the clogged artery to help prop the artery open and decrease the chance of it narrowing again. So this is, narrowing again is called restenosing. We don't want that to happen. Angioplasty can improve symptoms of blocked arteries, chest pain, shortness of breath. It can also be used during a heart attack to quickly open a blocked artery and reduce the amount of damage to the heart. So for stent placement, that's when a wire metal mesh tube is used to prop open an artery during angioplasty. It's a small diameter mesh put over a balloon catheter. It's then moved into the area of blockage to expand and expanded into place. When the balloon's inflated, the stent expands, it locks into place to form a scaffold that holds the artery open. So let's take a look at that. Here we can see the stent. If we threaded that up through the blocked artery and put that in place, you can see the stent opening up. So there's our scaffold or our stent in place, and then the catheter is removed. So the stent can stay in the artery permanently. It holds it open, improves blood flow to the heart muscle, and relieves the symptoms of chest pain. Within a few weeks of time, the stent was placed. The inside lining of the artery, the endothelium, grows over the metal surface of the stent. Some stents even contain medication that keep new clots from forming. However, oftentimes, patients that get a cardiac stent will have to take Plavix, which inhibits platelet aggregation. Or aspirin, which is, and aspirin, so Plavix and aspirin, either 80 to 325 milligrams of aspirin, which also inhibit platelet aggregation. Because while that stent is healing, the patient is at risk for restenosing or for new clots to form. And so we want to use Plavix and we want to use aspirin to prevent that. Other drugs that we will put these patients on include cholesterol-lowering drugs like atorvastatin. We may actually need to give them metoprolol, blood pressure medication, to decrease their blood pressure. And we also always want to remember as the nurse that in this procedure we use a contrast dye, like we looked at in the angiography video, to visualize the vessels during the catheterization. So it's really important that the patient is not allergic to iodine and has adequate kidney function as well. So we often ask them if they have an allergy to shellfish before a cardiac catheterization. Again, some of the drugs in the treatment for coronary artery disease, nitroglycerin, which we give for chest pain. We give Coumadin is another drug that we can use to decrease the risk of clot formation. Heparin, aspirin, we mentioned atorvastatin, clopidogrel or Plavix, and even fibrinolytic therapy. So let's kind of go through a couple of these. Nitroglycerin dilates the vascular vessels. It helps relax smooth muscle. It increases coronary blood flow by dilating the coronary arteries and improving blood flow to ischemic regions. Also drops blood pressure though, so we have to be careful after giving nitroglycerin that our patient doesn't have too low of a blood pressure and end up having orthostatic hypotension where they faint. If we give this under the tongue, it's got better bioavailability. We do not want to swallow the sublingual nitro. We want to make sure it goes under the tongue. We usually give 3 doses if necessary. So we give dose number 1. We wait 5 minutes to see if the chest pain goes away. If it does not, we give dose number 2. And we wait again to see if the chest pain goes away. If it does not, we give dose number 3. If the patient is still having chest pain, they need to go to the emergency room. Coumadin is a drug that interferes with blood clotting, and so it has a kind of a different mechanism of action to help keep clots from occurring. Sometimes patients that take Coumadin are actually instructed to avoid foods that are rich in vitamin K, like green leafy vegetables. So let's get this straight. We have a patient, they've got a cardiac problem. We thought they were supposed to have green leafy vegetables, and they are. We do want to encourage our cardiac patients to eat a healthy diet. However, the way this works is that green leafy vegetables can actually interfere. And so what we want to teach the patient is that a diet that is consistent with the amount of vegetables that they're taking in on a regular basis, along with monitoring their PT and INR, is perfectly fine, as long as we know what their PT and INR is and that they are taking in a consistent amount of green leafy vegetables on a regular basis. So the lab that we monitor when our patient's on Coumadin or warfarin is the prothrombin time and the INR, or the International Normalized Ratio. We want to remember that today's Coumadin dose actually affects our blood clotting 2 to 7 days later. As long as the patient's PT and INR is carefully monitored, Coumadin is a safe drug. Antiplatelet drugs like aspirin and Plavix or clopidogrel are drugs that help decrease platelet aggregation. And then we talked about our cholesterol-lowering drugs like atorvastatin. Lipitor is another name for this drug. We want to check liver function before and during therapy. It's important that the patient take this at the same time every day. And we want to encourage our patient also to continue eating a low cholesterol diet along with taking this medication. The fibrinolytic therapy, Retivase is an example of a drug that actually dissolves the thrombus associated with the myocardial infarction so that the myocardium can be perfused. And we talk about that golden hour. We talk about getting someone who's having chest pain to the emergency department as quickly as possible because time is muscle, right? So this Retivase, ideally, if given within the first hour after the onset of symptoms, can help reduce mortality rate in patients that are having acute coronary syndrome. So the time window is approximately 6 hours. So ideally, if we can get them in and get them fibrinolytic therapy within the first hour, that's the best possible outcomes. There is also a procedure, surgery that can be done called coronary artery bypass graft. And you'll hear people a lot of times refer to this as a cabbage. And what happens in this surgery is that they use the patient's mammary artery to bypass coronary arteries that are occluded. And so this new source of blood supply to the heart is usually distal to the occlusion. So let's take a look here. We can see here in this picture that we see a blocked coronary artery, and we can see this mammary artery coming off of the aorta. It's grafted from the aorta. It bypasses the blocked coronary artery, and it's attached to the coronary artery at the other end below the blockage. So this is a cabbage, coronary artery bypass graft. This is a major surgical procedure. The patient needs to be on telemetry where we're monitoring their heart rhythm. They are intubated, they're on a ventilator, they often have a nasogastric tube, a Foley catheter, chest tubes to drain the chest cavity of fluid and blood, so lots of tubes, time in the intensive care unit, IV lines through which fluids and nutrition and medicine can be given, an arterial line, which is a soft kind of a plastic catheter that's placed directly into the artery so that we can continually monitor the blood pressure and get arterial blood gas samples as well. A Swan-Ganz catheter is also used, and we insert this into a vein in the neck, and we thread this down into the heart and the pulmonary artery so that we can monitor the pressure and the blood flow within the heart. So after a cabbage, a patient will have to go through what we refer to as cardiac rehabilitation. And this recovery includes physical therapy, respiratory therapy, occupational therapy, diet counseling, an exercise program, and a medication regimen. So it's really important for the patients to participate and be compliant in their cardiac rehabilitation after the procedure. So that is all I have for today. Thank you for joining, and I think that covers coronary artery disease and acute myocardial infarction, and we will have more next time. Aloha.